Hello everyone, this is Professor Harkirat Bal and welcome to today's lecture on schizophrenia, spectrum and other psychotic disorders. When many people think about mental illness, I believe the image that often comes to their mind is someone going through psychosis, perhaps a client in a psychiatric unit. So in that sense, this topic can serve as a prototype for understanding serious mental illness. Now, this topic, along with bipolar disorder, is one of my areas of clinical and academic focus. I genuinely enjoy reading and teaching about these conditions, and most importantly, of course, taking care of a client who's suffering from these conditions. I really hope you also find this lecture as valued or engaging as I did in preparing it. I just know that it's going to be another long lecture, so I do apologize for that. So what I'm going to do is I'm going to divide this into two parts. So make sure you start with a part one, please. In part one, we'll explore some definitions, epidemiology, etiology, and then diagnostic criteria and so forth. Now, in part two, we will focus more on treatment approach. All right, let's dive in and don't forget to pause and take a bio break as needed. Okay, well, I'm going to have you answer this question for me. What is the difference between psychosis and illusion? Is there any difference? And if yes, what is the difference? I'm going to have you actually pause for 30 seconds and see if you can come up with a basic definition to make your case if there's any difference. Okay, so your time starts now, 30 seconds. All right, okay. So, and we'll talk more about this, by the way, in depth today. The definition, the very basic definition of psychosis is that when you have a client who loses contact with reality. So in other words, thought process is impaired. And this is when you may have hallucinations, either seeing things or hearing things that aren't there, or perhaps some delusions, false belief, not based in reality, right? So that's a psychosis. Now, illusion, on the other hand, is a misperception. There is an external stimulus or stimuli present, and you perceive in a wrong way. Now, the main difference here, the key point here is with illusions, you have external stimulus or stimuli present. Whereas in psychosis, there is no external stimuli. Okay, now that's very important. And I'm going to give you an example to make my point. Okay, so what I'm going to do is I'm going to actually give you an example to make my point. But before I give you instructions, if you are not driving, if you are safe at home, I'm going to have you close your eyes for this activity for a second, okay? So just pay attention. Again, close your eyes if you're not driving. Imagine this. You come home late at night and it's very dark. As soon as you open the door, the front door, you get this feeling that someone is sitting on the couch. You felt there was a ghost, and you quickly turn on the light and realize there's nobody there. There was nobody sitting on the couch, and you feel good, you feel relieved, and say, thank God no one is there. Now that was scenario number one. In second scenario, same situation or similar, I should say, you come home late at night, it's dark, and again, you feel like someone is sitting on the couch, and you turn on the light, and you see that this time one of your family members was actually sitting there, either your parent, sibling, significant other, and so whoever, right? And you laugh and say, ah, thank God it's just you. I thought you were a ghost. Now, You can open your eyes. My question to you is, which of these in these two scenarios was illusion and which is psychosis? So think about it again. You can pause and let me know what you think. All right, so here's my response to this. Scenario number one. Remember, this is when you walk in, it's dark, and you feel like someone is on the couch. You turn on the light, no one is there. You perceived a presence that didn't exist at all, right? So, and that is actually a false perception with no external stimulus. This matches the definition of psychosis, right? This is like a brief hallucination. You saw something that was not there. Now, please understand, I'm really oversimplifying this. I'm just trying to make my point. By no means I'm saying that this person is meeting the DSM criteria. If you ever felt this, that you came home and then you felt somebody was sitting, I do not want you to think that you have psychosis or any of the mental health issues. By the way, this is for education purpose only and not to self-diagnose. Please do not do that, okay? As a matter of fact, this person will not meet the criteria, but I'm just trying to make my point that at least for this example that I gave you, this was not illusion. The first situation was not illusion. It was actually a brief, very brief episode of a psychosis, if you will, even though we know that this is not meeting the criteria for DSM. Now, in the second scenario, when you walk in, it's dark, and you think someone is on the couch, maybe a ghost, and you turn on the light, and it was actually your family member, right? Parent or sibling, significant other. Now, there was someone there, but you felt that it was a ghost. Perhaps you misinterpret the image. Maybe it has to do with poor lighting, whatever the case is. Now, because there was external stimulus, this is actually an act of illusion, right? You perceived in a different way. Something was there, something there actually existed, right? So the second example would be illusion. Again, please never ever self-diagnose. I'm just making a very simple analogy here to make my point. Okay, well, here's another very wonderful and famous example of illusion, something that we call Ponzo illusion, who was a famous Italian psychologist, Mario Ponzo. Well, according to him, in real life, as we know, objects that are farther away, they do appear smaller on your retina. For example, right here, these lines appear smaller than the one in front of us, right? That's basic normal physics, if you will, right? Now, with the Ponzo illusion actually tricks our brain by flipping this logic, and here's how. Well, in reality, look at these yellow bars. In reality, both of these yellow bars are physically the same pixel length on the screen. So in other words, their width is constant and the length is the same, right? Now, because the track lines are closer together at the top, right here, right? Appears to be closer together, even though when we know it's the same, same gap, right? Now, the same size bar, even though these two yellow bars are exactly the same size, they appears to span a wider portion of the track in that space. Now, it's an illusion of context or optical illusion. The track lines get closer as they recede here. They're more narrowed. So any object between them appears larger relative to its surrounding. So pretty much our brain says, well, if that line is farther but still looks this big, then it must be physically larger. Okay, that's very interesting, famous optical illusion. Now, here's another silly example, if you will. All of these three lines, line 1, 2, and 3, they're actually the same in length, but they appear different. Seems like the line in the bottom is longer than the one on top. And then what happened is, look at these arrows at the end. These guys are actually creating this illusion. Remember, this is external stimulus, just the one that we saw in the previous picture, external stimulus, right? So that's another example. Now, another silly example would be when people apply makeup, or they talk overly nice to you. Now, even though these two examples that I just gave you, it doesn't really fool the eyes directly, if you will, right? But they can create this bias in perception, and they can create a perceptual distortion, you can say, similar to how illusions work. Okay, so the last example of illusions, I promise we'll be done with this after this. Over here, everything we hear is an opinion, not a fact. Everything we see is perspective, not the truth. So this person over here is counting as 1, 2, 3, and 4, and this guy says no, 1, 2, and 3. So again, another illusion. All right. So that's enough about illusions. Our focus is going to be psychosis. And remember, with the psychosis, there's no external stimulus. All right, well, now let's change the topic altogether and see if we can understand our brain a little bit more in depth, if you will, to see where does a psychosis come from, or especially our understanding of hallucinations, let's say, or delusions, and so forth, right, which is going to be the hallmark signs of psychosis. So let's understand brain sensory cortex. Now we can divide the levels into three processing centers, if you will. The first one is going to be primary sensory cortex. This is where you receive the information. As soon as you're looking at something, you are working at the primary center of the brain. And remember, we have a primary sensory cortex for all of the senses, for vision, for auditory and touch and so forth, right? So at primary, you're just receiving the information, okay, a received copy, that's it. Now with the secondary sensory cortex, this is where we start to analyze. We begin to put these pieces together and what that signal might represent. The third stop, or the final stop, is going to be tertiary sensory cortex. This is the final layer, which is responsible to recognize and compare the information. This really helps to understand if what I'm looking at is something new, or what I'm hearing is something new. Have I seen this before? Or do I know this? Like a memory, if you will, right? Is it a new file or old file? Can I compare this with what I have already and try to make sense out of that? I know it's a lot of information, but let me give you an example to make my point. So let me walk you through. So take a look at what you see on the screen right now. All of a sudden you see a script or text, right? Now, most of you are not going to able to read this, right? Because you're not familiar with this text, right? So, but I'm going to help you to walk you through this sensory cortex. How do you know that you are not familiar with what you see? First of all, are you able to see it? The answer is yeah. If the answer is yes, then at least we know that your optic nerve is intact, and then you have a primary sensory cortex working in a way that you received the information. And again, I do apologize. I know I'm oversimplifying things. Stuff is usually more complex than this, but I'm trying to do like a basic introduction, if you will, right? So you're able to see it. Now, another interesting thing happen here is when you register from a primary sensory cortex and you go into the secondary and you're trying to analyze the information. With analysis at the secondary sensory cortex level, you made a decision that it is a red in color, right? Because you were able to analyze the color. It's a red, and under tertiary, you're trying to recognize and compare, and your brain is telling you that I do not have any past memory. I don't know what this is. I kind of sort of know that it's not an English alphabet. The reason we were able to see that and make that decision because we do have a past memory of English alphabets, right? So it's not English, it's not a tree, it's not a plane, it's not an animal, it's not a bird. We know that because we do have a past memories, right? So, but I'm not able to tell you what I'm looking at. All I know is it's a red in color and some kind of a handwriting, I don't know, script. Okay, now what? Well, let's go back to primary sensory cortex again. Okay, well, I received the information, I can see it, and also now I can differentiate. Now I have English alphabets, right? It look very familiar to me. I can analyze it and I can kind of sort of compare it. Another interesting thing that I noticed, it's no longer red in color. The color has changed. It's a green. And then, but I can't read it, or maybe you can read it, but you still have no clue what you're reading because you do not have a past memory. So it said cha garam hai, and you read it simply because you're going off of English alphabets and you have no clue. Now what happens? Primary sensory cortex says I can register this information and I have no problem analyzing at a secondary level. The color has changed. It's a purple now, and it's English alphabet, and I can compare this new information with the past information, and I can recall that, and I can tell you, oh, tea is hot. So now we are making sense now, right? We're talking again. So same thing happens. This was just one example with the visual, right? Same thing happens with auditory. When you talk to somebody, you can say, yes, that sounds like Punjabi to me, or Spanish. I know it's Spanish, but I'm sorry, I don't know. Even though I know you're talking to me in Spanish or Italian or Dutch and Russian and so forth, but I'm sorry, I can't answer that question because I don't know how to speak that language because my tertiary sensory cortex has failed. It's telling me that file is not found, if you will, right? Okay, and so same thing happens with all of the senses. With the touch, we know that the smell, that's something that we are very much familiar with, right? And same thing with the touch and vision and so forth. Okay, now why am I sharing this information with you? How is this relevant with our topic today? Well, because in psychosis, dysfunction in any of these levels, especially in tertiary cortex level, it can result in hallucinations, let's say. So the brain may misinterpret the internal signals as external stimuli, right? Leading the person to see or hear things that aren't there. So that's a very important concept. So people with psychosis often have abnormal activity in primary and secondary sensory cortex, especially with auditory cortex. We know that has been linked to auditory hallucinations and visual somatosensory cortices may be involved in hallucinations, delusions, misperceptions, and so forth. Now, with the tertiary sensory cortex, also associated area in the temporal and parietal lobe often show this impaired integration of a sensory input with a memory and reality. So what I'm trying to say here is that damage to any part of the brain that may have impact on, let's say, on temporal lobe. For example, maybe a tumor that is growing on that part of the brain, right? You may have a client who's all of a sudden now hallucinating because of that tumor. So it's worth getting MRI and further testing, if you will, especially if symptoms are not making sense. I know we'll talk more about the diagnostic criteria, but if all of a sudden you have a client who's a 45-year-old male present to your clinic with this new onset of hallucinations and perhaps have a headache or head injury and so forth, it's worth getting images done because they're not of a typical a client who's 25-year-old, let's say, because we know that schizophrenia is usually diagnosed in early like 20s and mid 20s or so forth, right? So that is the point I'm trying to make here. Now, talking about the temporal lobe, remember it also play a very important role in distinguish between what's familiar and what's new. This is a process critical for making sense of everyday life, right? So we know the concept of deja vu, that literally means I have already seen it, already seen, and jamais vu, which means never seen before, totally opposite of deja vu, right? Now, I'm not saying this is not necessarily a pathology and has nothing to do with what we will diagnose a client later on using DSM criteria. This is not a diagnostic, but I'm just trying to make my point with the role of temporal lobe in general, where it helps us to understand what's new and what's old, what's familiar, and also if there is any damage to the temporal lobe. The example that I gave earlier was perhaps a tumor or maybe a brain bleed and so forth, right? So remember in deja vu, this simply refers to the sensation that whatever the current experience you're having, you're very much familiar with it, right? So you've seen this before or have been here before, right? Even when it's happening for the first time. Now, this is believed to result from the temporal lobe incorrectly or falsely flagging something as if this is a previous experience, right? That's what this is all about. And with jamais vu, it's totally opposite. It's a feeling that something very familiar suddenly seems strange or unfamiliar. Have never done this before. I don't know how to go home. I have never taken that route before, or something like, I don't know you, right? So that type of behavior. Now, in psychosis, this may take on extreme forms, such as seeing buildings made up of cotton, or believing people are mechanicals and so forth, right? Now, these altered perceptions, they stem from dysfunction in distinguishing reality from unreality, which is, remember, a hallmark of psychosis disorder, right? Psychotic disorders, I should say. And now understanding these phenomena really help us as a clinician to assess deeper disturbances in person's ability to process reality. So I know I'm throwing a lot of terminology here, but I'm just trying to make my case, and this will really help later on with differential diagnosis and so forth. Now we're going to get into the diagnostic criteria, like a DSM criteria. So the first one on the list is, I'm going to start off with very brief psychotic disorder. So you have a client who had an episode of psychosis, and remember we have already defined that term. I said psychosis is when you have lost touch with reality, right? You have a loss of rational thoughts, or either hallucinations, paranoid behavior, delusions, and so forth, right? So that's psychosis. Now, duration is important. So everything in so far that we talked about was pretty much like a general generic information. Now we're going to get into duration, and DSM talks about number of days or weeks or months and or years and so forth, right? So with a brief, symptoms are present at least one day. We'll start with the day number 1, but less than 1 month. Okay, so if you have a client, this is day number 25, it is still a brief psychotic disorder. Now, the onset is a sudden and include at least one of the positive symptoms of schizophrenia. And we'll talk more about a positive and negative symptoms in a few minutes or so. But just remember for now that a positive symptoms such as auditory hallucinations, visual hallucinations, and so forth. So that is your positive symptoms. So you have to have at least one, and so at least one symptom for at least 1 day. That's easy to remember, and less than 1 month or within a 1 month, right? Be careful about this population because they're at a very high risk of suicide. All of a sudden, this is sudden. Things are not making any sense for them, and unfortunately, younger patients are at a very, very high risk. So very important concept. Now, the second type of disorder would be schizophreniform disorder. Now, very, very similar to what we just talked about earlier, but look at the time frame now. So now for at least 1 month up to less than 6 months. Okay, so the symptoms are present. The previous one, brief disorder, was 1 day to less than 1 month. Now we pick up from there, 1 month all the way up until 6 months. All right. About 33% of these patients will show full recovery. However, the rest will be diagnosed with either mood disorders or schizophrenia. So we need to keep an eye on these patients. What I'm trying to say is what will happen is 33% will recover. So within that 6 months or so, those who do not, after the 6-month mark, they are either meeting the criteria at the time for a mood disorder, like a bipolar, depression, mania, or they will meet the criteria for schizophrenia, which we will go over in depth in a few minutes. Okay, now this is very interesting diagnosis, and people usually struggle with this diagnosis. So I really want you to pay attention, please. Now, there are a couple of things going on. First of all, look at the name of the disorder. It says schizoaffective disorder. So divide this into two. So the first is going to be schizopart, like a schizophrenia. Okay, so I know we haven't talked about the criteria yet, but we will. But just remember that. Now, the second part is your affective behavior. So more of a mood disorder. We talked about mood disorder in the previous lecture, right? So what happened is, look at the criteria real quick. And A is you have uninterrupted period of illness during which there is a major mood episode. That's where the affective part comes in, right? Mood episode, either major depressive or mania, so one or the other. And on top of that, you have a client who's meeting the criteria or criterion A of schizophrenia, which we will talk about that in a minute. In other words, you have a client who's meeting the criteria of schizophrenia, at least criterion A, and on top of that, meeting the criteria of a mood episode, either depression or mania. Now, please note that the major depressive episode must include a criterion A. In other words, remember, go back to my mood disorder lecture and review the criteria for major depression. So what I'm trying to tell you here is that when you say that, oh, the patient has depression, make sure they're actually meeting the criteria A of depressed mood. So this is the DSM criteria. Okay. Now the second criterion is B, delusions or hallucinations for 2 or more weeks in the absence of a major mood episodes, depressive or manic, during the lifetime duration of the illness. Now this is very important. Now remember, in criterion A, I said make sure the patient is meeting the criteria of schizophrenia, right? Well, that makes sense. Here we are trying to make it very clear that make sure that one of the criteria is either delusions or hallucinations, right? From psychosis standpoint of view, make sure delusions or hallucinations for 2 or more weeks in the absence of major episode. In other words, delusions occur and they occur for at least more than 2 weeks when mood disorder is not present. In criterion A, I said make sure both items are present. Both items are present at one point, and then there's a time in their life when you do not see any symptoms of a mood disorder, no depression, no mania. However, you see delusions or hallucinations for at least 2 weeks. That's very, very important. And I probably will come back to this again in a few minutes to make my point. Criterion C, symptoms that meet criteria for a major mood episodes are present for the majority of the total duration of the active and residual portion of the illness. Well, that makes sense. So remember, we're dealing with the two things here, schizophrenia and affective. And I said both of them has to be present. Then criterion B says the symptoms of schizophrenia, either hallucinations or delusions, make sure they're present for at least 2 weeks when mood disorder symptoms are not present, right? Now, number 3 is saying symptoms that meet the criteria for a major mood episode, either depression or mania, they're present for the majority of the total duration of the active and residual portion. They are, so at least not for the 2 weeks. They're not present. They're absent here, but they are present for the majority of the time. Criterion D, the disturbance is not attributed to the effects of a substance use. Well, that makes sense. Make sure we rule out substance use or medication use disorder, right, from another medication. For example, cannot be caused by alcohol or any other drug, like any drug that can actually increase your risk, like prednisone can do that, right? I mean, prednisone induced psychosis and so forth, right? Okay, then specify whether it's a bipolar type or depressive type. Remember, we are saying it's affective disorder. And affective has 2 poles, right? So one side of the pole is depressed, and second side of the pole, when the pendulum is swinging to the opposite direction, remember, that would be bipolar. So we have to specify what exactly are we dealing with. So I will say, let's say a 35-year-old male with schizoaffective disorder, bipolar type or depressive type. Now, how do we know which one is which? Well, bipolar type is when a manic episode is a part of the presentation. Major depressive episode may also occur, but the primary is going to be manic phase. Now, the depressive subtype is when you only have a major depressive as a part of. Remember, we talked about this. When you have a client who is just on this part of the pole, right? We call that unipolar. If that's all you see, just unipolar, that would be schizoaffective disorder, depressive type. Once you have at least one episode of mania, and we call that bipolar, right? That would be a bipolar type. Even if you have a client who has a depression, we will not call that a depressive type. That makes sense. We talked about this concept. And if you are still struggling with this, make sure you please watch mood disorder lecture, both part 1 and part 2. Okay, so in summary, schizoaffective disorder if psychosis is present for more than 2 weeks without mood symptoms, is schizoaffective disorder. And before that, of course, you have to have a client with psychosis. The symptoms are present, both symptoms, well, not both, either depressive or mania. So in other words, the symptom of bipolar or affective disorder are present together. So they, number one, they're present together, and number two, psychosis is present for 2 weeks without mood symptoms, and we will call that schizoaffective disorder. Now, remember I said if psychosis is present for more than 2 weeks without mood symptoms, and we call that schizoaffective disorder, what if you have bipolar disorder with psychotic feature? What is that all about? Well, you have a psychosis, a client who's going through psychosis, that occur exclusively in the setting of a mood disorder, either mania or depression. In other words, the client is not meeting the criteria for schizophrenia at this time. So psychosis occur only in the setting of a mood disorder. That would be, and if they're happening in the setting of mania, we'll call that bipolar disorder with a psychotic feature. Remember, in this setting, you are not going to see psychosis without mood disorder. If you see that, the chances are you're dealing with schizoaffective disorder. Okay, but if you always see psychosis with mood disorder, then that's a bipolar, because by definition, this cannot be, if it's always with psychotic features, bipolar, and by definition, that cannot be schizoaffective disorder. How about just pure major depression disorder with psychosis? In other words, you do not see mania at all, then we'll call that major depression with psychosis. So psychosis occurs exclusively in the setting of just depression. I hate to say just, it's a major depression, but the point is just here simply means you do not see mania, so it's not a bipolar, and you do not see psychosis when there's no depression, and therefore this cannot be schizoaffective disorder. I'm going to repeat this to make my point. If you saw psychosis or any symptoms of schizophrenia with either depression or bipolar together, and then for 2 weeks without these mood symptoms, that would be schizoaffective disorder. But here you're only seeing psychosis with either bipolar or with only major depression, and therefore this is not meeting the criteria for schizoaffective disorder. Very, very important concept. Make sure you please try to understand that. And if you still need further clarification, please do not hesitate to email me. Okay, now the last point I promise here is unspecified psychosis. Now, this is when you have a client who is not meeting the full criteria for any of the specific psychotic disorders, including schizophrenia, of course, which we haven't covered yet. I'm saving that at the end because that's a main focus for today's lecture. So when the patient is not meeting the criteria for any of the above, or you do not have enough information, or you don't have enough time, and maybe in case of like an urgency, maybe this is right in the ER, and you just need to treat this patient, and then you have to have a diagnosis in the chart, so we can give a diagnosis of unspecified psychosis. And we just understand in psych, we use unspecified a lot. Well, in medicine in general, we do that a lot, but it is our responsibility to go back whenever we have a time or situations allow, to go back and collect all the information, make some phone calls, do some a chart review, get collateral information from family and so forth, and you can have other IDT member to help you, such as maybe nursing staff or social work and so forth. We should make every attempt should be made to change the diagnosis if possible from unspecified to something that is more specific. I have seen sometimes patients in the healthcare system, they're seeing the same provider or many providers for that matter for years and years and years, and they still unfortunately have unspecified psychosis as a diagnosis. I'm not saying it's not possible, but come on, we should try. We should give a diagnosis at that time. Call it if it's is it a bipolar? Is it schizophrenia? What is it? We should know by then, right? So my point is, if you have to use this in case of emergency, fine. I do that once in a while when I get a phone call. My patient needs something. Okay, here's a risperidone or a Haldol or whatever. And what's the diagnosis? Well, I don't know. Let's call it unspecified. But then I try my best to go back and give them a proper diagnosis. All right. Well, next we have is schizophrenia, and we are going to spend a lot of time on this topic for the rest of the lectures, both in part 1 and part 2. But for now, very brief introduction of the criteria. You have a client who's presenting with a psychosis, let's say. So the first question is, do we have at least 2 or more of the following? That's a criterion A1 through A5. So you need 2 or more, and then make sure that each of these, either A1, 2, or 3, are present for at least 1 month. So there's 1 month period or less if we were able to treat these symptoms. If we were able to intervene early on and we treated them, then that's okay. But usually at least 1 month, and that most of the time, by the time we get our patient in the facilities, it's almost always more than 1 month. But it's theoretically it's possible that we were able to see the patient within day number 3 or 4, right? Okay, now so the number 1 criteria I mentioned, you need 2 or more of the following for 1 month, at least 1 month. And at least one of these must be either A1, which is delusions, or A2, hallucinations, or A3, which is disorganized speech. So make sure that, remember I said you need 2 out of the 5. And out of these 2, one of them has to be either A1, A2, or A3. In other words, you cannot have number 4 and number 5 and call that schizophrenia. That will be something else then, so look for another differential. Perhaps it's a depression with psychotic features, especially if you have a negative symptoms like diminished mood and depression and so forth. We'll talk more about positive and negative symptoms in a few minutes. Also, if it's okay, we'll talk more about that. Give me 1 second. Second criterion B, I should say, is make sure there's a overall impact on the ADLs, work, school, and so forth, which is very common criteria for many disorders. And then criterion C, there's a continuous signs of disturbances that persist for at least 6 months. So make sure the overall is a progression for 6 months. If it's a less than 6 months, remember we talked about another differential. Less than 6 months was schizophrenic form disorder. Remember you had a similar setup where you needed 2 or more of these symptoms, but the time frame was at least 1 month and less than 6 months. This is during 1 month period, but at least 6 months. It's above schizophrenic form disorder, if you will, right? And then of course, option D, E, F, rule out other differential diagnosis, rule out schizoaffective disorder, rule out bipolar, depression, rule out substance use disorder, rule out any other medical condition, and so forth. Okay, so let's put everything that we have covered so far in a clinical scenario, if you will, and see if we can actually apply the information, because this is all about application, right? So far we talked about a concept of psychosis, and I mentioned that psychosis is when you may have a client who has lost touch with reality, and then some symptoms I mentioned was either hallucinations, delusions, and so forth. Then we got into some differential diagnosis. Is this unspecified? Is this a brief episode? Is this a schizophrenic form or schizoaffective disorder, schizophrenia? Is this I don't know, a bipolar with psychotic feature, or depression with psychosis, and so forth? So I'm going to give you a scenario and see if you can give me a final diagnosis, if possible. Okay, so I'm going to read the case for you real quick. So Maria is a 28-year-old female. Just so you know, this is a fake patient, if you will. I just made this case. This is not a real scenario at all. Okay, so Maria is a 28-year-old female who presented to us. She's accompanied by her sister, and pretty much she's giving us these erratic behaviors over the past 3 weeks. So make sure you're taking notes, and then especially the timeline, right? So it's been going on for the past 3 weeks. She had recently quit her job. All of a sudden, she's claiming she was called for a divine mission. She spent thousands of dollars on spiritual artifacts online. She had not been sleeping more than 2 hours a night, and she's pretty much euphoric, energetic, and very talkative. So remember, I really want you to think, is this a depression? And then we talked about a bipolar in different lecture. So what exactly is going on? Usually a client who is not sleeping will report that I'm very, very tired and very fatigued. She's telling you that, oh, I'm sleeping for less than 2 hours or so, no more than 2 hours, but she's very energetic and very talkative. Okay. Presenting symptoms during her psychiatric evaluation, she speaks rapidly and jumps between topics, often returning to her belief that she is receiving those coded messages, if you will, through street signs and television commercials. So people are talking to her through TV and so forth. She reports that the voices of angels guide her actions and warn her about the impending catastrophe, and her mood appears elevated, and she shows signs of grandiosity. She's making statements such as, I am the chosen one to save humanity. Okay, so pause for 30 seconds or so, and see what you can get from this slide. Now, this is her mental status exam. Very briefly, mood affect is euphoric and expansive. Her speech is pressured, and the thought content is delusions, of course. Remember we talked about references. She's telling us that people are talking to her, or they're sending messages through television. Perception, we see there's auditory hallucinations. She's hearing voices, angels. Needless to say, her insight and judgment is poor. Now, her course in the hospital over the 2 weeks when she stayed, her manic symptoms gradually, she stabilized. They gradually improved, and with the treatment, of course, but she continues to report hearing voices and remains preoccupied with her belief that the messages are embedded in the television programs. So these psychotic symptoms persist in the absence of elevated mood or depression for more than 2 weeks. So I think I gave you enough information here to make my case. So again, pause and see what else is going on here. All right, well, let's see what diagnosis you came up with. So Well, number one, she has major mood episode, remember, manic, and at the same time she was meeting the symptoms of schizophrenia. Remember, there's the delusions, hallucination, disorganized speech. So she has both mood episodes, manic phase, and she's meeting the criterion A for schizophrenia. So this is not just a schizophrenia. Remember, there's a mood episode as well. Delusions and hallucination, they persist for more than 2 weeks in the absence of mood symptoms, right? And mood symptoms, which was mania in this case, was present for the majority of the total illness duration. And I told you there was no mention of substance use or any other medical conditions, and therefore our final diagnosis in this case is schizoaffective disorder, bipolar type. I hope that's what you got as well. Okay, remember earlier I mentioned that the rest of my presentation is going to be on schizophrenia. So let's dive in. Now, as we know that schizophrenia does not develop overnight. It usually follows a very progressive course that can be divided into several distinct phases, if you will. The first one on the list I have is a pre-morbid. It's a pre, right? Before that morbidity, if you will, right? This is before any clear symptoms appear. The individual may seem withdrawn, right? Or may have poor academic performance, very subtle cognitive or social deficit. And we usually overlook these. Most of the time, when we have a client in the hospital and we are getting collateral information, and then we go back and ask either a parent or aunt or uncle or grandparents, can you tell us more about your child? Tell us when he was in, I don't know, elementary school or even preschool and stuff like that. And then this is when we get the information that, oh yeah, I remember one night, he looked odd, if you will, right? And so they'll give us some more information, and this is usually like a retrospective a chart review, if you will, right? Because these symptoms are not clear. I mean, we cannot call this behavior as a schizophrenia. It's way too early, right? Then you have something that we call a prodromal phase. Now, in this phase, subtle symptoms begin to emerge. They may include some social isolation, some odd behavior, decreased motivation, and usually a warning stage that will lead to the first psychotic break, if you will. And so the example would be, you expect a child or teenager to look forward to a birthday party, let's say, or cousins usually hang out together or play together and so forth. But now you see all of a sudden some social isolation, or sibling might say that, oh yeah, I remember when I walked into his bedroom and he appears to be talking to himself. Well, I just ignored, I just closed the door, but I didn't know, so that would be like a prodromal phase where symptoms are there and family member kind of sort of see that now. But again, nobody knows what's going on, right? So we don't have a clear diagnosis at this time. And then unfortunately, here comes a stage where you have obvious symptoms, acute illness. Psychotic symptoms are present, everybody can see that, and usually that's what lead to the hospital, right? To the ER, I should say. Somebody's calling 911, either family or neighbor. This is where those symptoms are very obvious, like delusions, hallucinations, a speech is disorganized. We're going to talk about these symptoms in detail, by the way. So this marks the full onset of the illness. And usually this is when they get the formal diagnosis. And then that stage is followed by stabilization phase. This is when the treatment occurs in acute care settings. When you see clients, we make rounds, this is where usually we treat them in an acute phase, but this is the goal where we want to see them. We want to stabilize them, right? That's our goal. Some patients may, regain most of the function, right? Although most of them do not go back to the pre-morbid level. There is some deficit. There's a residual effect. One thing that I like to tell my students is, and my colleague is, think of each episode of schizophrenia or psychosis, I should say, or even mania, as like a CVA, like a stroke, a insult to your brain, right? And then every time we have a mini attack or TIA or stroke even, there is damage, right? Residual deficits. Same principle applies here, which we didn't know back then, but I firmly believe in that it is a responsibility as a clinician to really identify these symptoms and stabilize them, because if we don't do that, if they don't stay in a recovery phase, the relapse chances are very, very high, and then each episode is gonna cause more damage, and sometimes it's irreversible damage, so we have to be very, very careful. So anyways, I know I moved very quickly from stabilization phase to recovery. Recovery is, where, most people, they may not, fully recover. I know most of my clients, I do treat, they're inpatient, and the damage, the burden is so huge, and I know that they are not gonna enjoy the same lifestyle that unfortunately the one that you and I may enjoy. So very important concept. Now, why are we talking about these phases? Because if we recognize these phases early on, and we do early interventions, and come up with this long-term plan for them, we can minimize the further damage, if you will, right? So early detection and interventions are very, very important. Okay, so let's talk about the presentation. Well, in men, these symptoms, they usually come in early to mid 20s. As I mentioned before, this is a disease or disorder of early onset, so usually in mid 20s or early 20s in men, and in women it's usually late 20s. For some odd reason, men are slightly more diagnosed with the schizophrenia than female, but in female population, the symptoms do come later in life than men. All right, so usually the median age would be around 18 to 25 for men, and maybe 25 to 35 for women. Okay, and symptoms of schizophrenia often evolve slowly over years. In the early stages, formal thought disorder may be very subtle and hard to recognize, but as the condition evolves, language becomes even more bizarre. The person lose ability to communicate, and as we know, it's a chronic disorder, and not every patient is going to take the same course, right? No two patients diagnosed with schizophrenia look the same or behave the same. And that's true for so many other health conditions, by the way, you know that, right? Because you can have a high functioning client, who's able to maybe finish college and have a job and so forth, right? And then you may have another individual who's not able to do any of the functional ADLs, if you will. Okay, well, let's talk very briefly about the epidemiology and pathogenesis of schizophrenia. Well, according to WHO, World Health Organization, this is listed as one of the top 10 illnesses that may contribute to the global burden of disease. And I also came across one study where it talks about the overall prevalence of schizophrenia, which is approaching about 1% internationally. So that's a huge number. Okay, so let's talk about the pathogenesis now. While we really don't know the exact cause of schizophrenia, but we do have several hypotheses, theories. Just like anything in mental health, we believe there are multifactorial etiology, if you will, right? Pretty much anything that can go wrong with the brain may cause these symptoms, such as a TBI, like a traumatic brain injury, even early on when mother was pregnant. So I think it's important to get that collateral information from parents, maybe grandparents, and so forth. Tell us more when mother was pregnant, any hemorrhage, any preterm labor, hypoxia, like fetal hypoxia, any type of maternal infections, right? And even some substance use disorder, any history of alcohol, cannabis use, cigarette smoking, or any childhood trauma right after delivery, any complications, or when the child was growing up, any type of either physical or sexual abuse, anything that can cause a trauma, I should say, right? Genetics. Now, genetics play a very important role. We know the role of genetics in mental health. There was a study that I came across that a person with both biological parents who were diagnosed with schizophrenia, that person has up to 40 to 50% risk of developing schizophrenia. So that's a huge burden, right? And we know the role that play, and that's so important to get family history, very good family history. I always ask this question: do you have anybody in the family with a similar symptoms, similar presentation, any psychiatric family history? I have had many patients with a very strong family history. For example, I think a couple of months ago, I had a client with one of the grandparents had depression, aunt had a bipolar, and one of the cousins and a niece, and then of course my patient as well. So that's a strong family history. I actually had a patient took care of twin brothers. Both of them had schizoaffective disorder. We'll talk about that in a minute. And I believe I put them on risperidone, and it was very interesting how one patient did very well and second patient didn't. So that tells us, even though genetics play very important role, but there has to be more than just genetics, right? So there's environmental. You never know what path your patient is going to take. Otherwise, it'll be easy way out. If genetic was everything, then we can give a medication, then everybody will react the same way, right? And we know that's not the case. So that tells us there has to be more than that. And then what a perfect segue into the neurotransmitters discussion, if you will. We believe neurotransmitters play a very important role. More specifically, dopamine is a key player. We believe it's the increased level or hyperactive dopamine, more specifically at D2 receptors. We'll talk more about this concept in depth actually in my part 2 when I talk about management of schizophrenia. But now we know that it's actually more than just dopamine. Serotonin plays a very important role. That's your second generation medications, along with the dopamine, of course. Now we have a little bit better understanding of the role of glutamate. Remember, glutamate is the excitatory neurotransmitter. Role of GABA, that's your inhibitory neurotransmitter. And also now we know the role of acetylcholine that plays. So that's new, some new medications coming in. But anyways, we'll talk more about this in depth, I promise, in my part 2 lecture. Okay, remember I said that I will go in depth with the diagnostic criteria, so I really recommend you bring your diagnostic criteria in front of you again and then follow that. The first one on the list was criterion A, and that was that you need 2 or more of those 5. Remember, A1, A2, A3, A4, A5 for at least 1 month. And then on top of that, I said at least one of those must be either A1, 2, or 3. So we'll start with A1, which is delusions. Now, what are delusions? Well, it's a false belief that misrepresent either perceptions or experience. In other words, it's a false and a firm belief, and it's held very strongly despite evidence. I mean, you can't, even though you have an evidence, you know it's false, but they are not going to believe that, right? So DSM talks about culture and religion and so forth, right? So make sure that belief does not originate from their social culture or a religious belief or upbringing, right? Because that wouldn't be nice. So especially if that is not your culture, it's so easy to question and judge people, unfortunately. But we have to be very, very careful, and DSM is very clear on that. If that belief is coming from their cultural background, that is not meeting the criteria. For example, if you have a client who firmly believes in that some animals are to be worshipped, or that they're worshiping a snake or a cow, and or they consider special, I don't know, either there's a statue that has a power, or angels have healing powers, or they hear voices. In some cultures, it's very acceptable that you hear voices and so forth. So that will not be a diagnostic criteria. All right, well, let's talk about some examples that fall under different types of delusions, if you will. So the first one on the list is delusions of grandiosity. This is where people believe that they are very important, a perception of importance, right? They believe they have special powers, they're famous, either kings or queens or with high status. I remember one time a client told me that he had 2 PhD degrees, not 1, but 2. And of course, the first thing we do is we always verify that with the family to get that collateral information, because that's possible. You can have a client with schizophrenia who might have a doctorate degree, or and so forth. Why not? So, but anyways, we were able to confirm, and then I believe that they told us that no, that's not true. He was actually at one point working on his GED, but maybe he got confused, I don't know. But the point here is always a double check. Delusions of paranoia. Now, this is very, very important and very common, actually. Unfortunately, people believe that others are going to harm them, and that delusion usually starts at home. Parents are going to harm them, or they're going to poison their food, and that actually becomes very well, all of these are carry huge risk, but the problem with the paranoia for some patient is, especially when they feel that somebody's going to poison them, is that they stop eating, and that becomes a huge problem. Especially I've seen that in inpatient as well. So make sure you have very good skills and try to convince them, okay, especially in the beginnings when they're going through psychosis, and we are giving them medications hopefully to help them. And is there anything you believe you can eat, especially you must be very hungry, you haven't had food for hours or days, And if you do not trust anybody in the kitchen, can we offer you some fruit, like, I don't know, like orange or banana, something that you can wash and peel off, and you know that it was not made in the kitchen, and so forth, right? Something like that. One example I have here with the delusions of paranoia is someone has removed my internal organ and has replaced them with the hidden cameras without leaving any wounds or scars. Because you can ask them, I don't see any scars, right? They'll say, well, I know that. Then they did not leave any scars. Now, I'll give you two interesting examples on this. One time I actually had a patient who had a very remote history of lap chole, laparoscopic cholecystectomy, and somebody, and he was young at that time, and somebody must have told him that we're gonna go inside and I'm gonna put cameras and I'm gonna remove an organ, in this case maybe gallbladder, I don't know, and there wouldn't be any big scars or open wound, anything like that. Who knows how they explained the procedure. I'm sure they did a wonderful job at that time, but now you have a client who has underlying psychosis or delusions, and he firmly believes that that's what we did. We put the cameras inside his body, and every time I would go, he'll say, well, can you remove that camera that you guys put in? So, and I go, what exactly is he talking about? So when I did a chart review, then I go, gosh, he does have a history of lap chole. Now, one time, another example is, I remember when I was making rounds, I had to increase this client who was going through psychosis, and more specifically delusions of paranoia, and I increased his medication, but I wanted to get the EKG as a baseline, and we'll talk more about EKG and all that when I talk about medication management, because it can prolong your QTC and so forth. Anyways, so I told the nurse, can we get EKG? Next day, and when they were getting ready for the EKG, and then the patient asked, what are you doing? What is this? And then the tech, I think, told the patient that, he ordered, it's nice, it's a machine, and I'm gonna just look into your heart, so I'm gonna put some, I don't know, wires on your body, and then he's gonna look at your heart, make sure everything is doing well. Well, that didn't go well, right? You have a client who's already paranoid, and then you're telling them that I'm gonna put some wires on your body and then look at your heart. Well, of course he refused, and I had to do a lot of like a damage control, if you will. Okay, now another one here is referential delusions. This is where they believe that some common events, such as passages in the song, or those clouds in the sky, are all about them, or they're talking about them, or they're giving them messages, getting a message through the television, a news anchor, she's saying that your cat is in danger, and then I need to go and then help my cousin, and so forth, right? So it's very, very interesting and very, very bizarre. Now, the last one on the list is actually, it's not that common, but I saw that twice. So gosh, and the first time I saw that, I didn't know. I had to, look it up. Capgras syndrome is where you have delusions of doubles. Patients falsely believe that an individual has been replaced by an identical person. So I had a situation, I was at the acute hospital, and then admitting that patient at the time, this was during my training, and the patient said, well, I do have, I believe, like I don't know, 1 month old, or couple of months old, let's say, baby, who has been replaced by another baby, and then he was looking for this child, and not sleeping and not eating, and then and we were able to confirm. We called the significant other, and then they told us, no, baby is home, baby is safe, he has been saying this. And we were able to even do some further investigation and so forth. And then we said, well, according to your mom and your wife, you remember your baby actually had a mark or a mole, and then this baby also has that, so this is your baby. And then he goes, no, trust me, I know, I saw that mark, but this is the identical person with the mark, and that's not my baby. It was really sad. We were able to actually treat this patient in a few weeks or so with psychotropic medications, of course. So very interesting. Okay, now A2, so that was A1, delusions. A2 is the hallucinations. Hallucinations is a sensory experience. There's not any external stimulus. We talked about that, right? Otherwise, that would be illusions. Remember that? Okay, but a client is perceiving something, right? Now, and then this will apply to all of the senses, by the way, right? The first one on the list is auditory. Now, auditory hallucinations is what client may hear what others do not, right? So do you, the way I ask is, do you often hear voices that other people may not? And you have to be very careful the first time when you ask these patients. I don't like to use the terminology hallucination, especially in the beginning. I simply will say when the patient, when we don't feel well, and sometimes when we are depressed or not doing well, mental health is not well, some people hear voices. Has that ever happened to you? And then the patient will say, yes, I hallucinate, and then I'll go, fine. And then once they tell me, then I feel comfortable calling that, right? Okay, now I'm going to spend a minute on this topic because that's important in my opinion. Few things about auditory hallucination. Number one, these, from a diagnostic standpoint of view, these hallucinations are clear and they're intermittent and they're paired with delusions. What do I mean by that? Well, first of all, clear in a way that people hear voices just like you are listening to me right now, and then so I'm real, by the way, and so that is, it's a clear, just like if we're having conversation. Okay, so it's a clear voice, I should say. So then it's intermittent. In other words, it comes and goes. It's not a continuous. There is a time when patient does not hear voices. Okay, so it's not a non-stop 24/7. Now everybody's different. Some patient hear them frequently throughout the day, but there will be times, especially maybe at nighttime, and who knows, if they're busy, they're distracted. So it's intermittent, but the frequency varies. And they're paired with delusions. In other words, remember, delusions, I said, it's a firm belief, even if we have evidence. Not only they're hearing voices, they believe in those voices. They believe that voice is real. I am talking to somebody and he's talking back to me. And not only I'm hearing this, I believe in that, and that's a delusion, right? So you're meeting that criteria, both criterias, if you will. Visual, see what's not there. So do you often see things that other people do not see? Some people see bugs or shadows or people and so forth. I actually had a client one time who told me about auditory hallucination, and he goes, I don't know, he goes, when my phone rings, he goes, I don't even know now if this is real or this is part of my hallucination. So how sad is that if you think about it, overall impact of these hallucinations. And I always ask my students, when you study and then you want to be in a quiet environment and make sure that nobody's bothering you, can you imagine if you're going through psychosis, especially more specifically auditory hallucinations, and trying to live your life with that? And unfortunately, these hallucinations, auditory hallucinations, are not nice. These voices are usually, not always, are asking you to do something that's wrong or bad, harm yourself or someone else, or you're not a good person, you can't do it, you're a failure, and so, stuff like that. So can you imagine, reading a book or doing something productive, and then voices are telling you can't do it, so you can't concentrate. So that's a huge thing. Number three is tactile. You feel bugs crawling, on you. Be careful. Cocaine can do that as well. So make sure that should be differential if that's all you have, just tactile hallucination. So rule that out. Again, history is very important. So remember I said all of the senses, right? Olfactory, art, smell, and of course the taste. Now, out of these five, the most common is your auditory hallucination. Somebody asks you what is the most common type of hallucination, it'll be auditory hallucination. Very, very common. Usually it's a combination of auditory and visual. All right. All right, well, A3 is disorganized speech. Well, as you can tell, this is where you're going to have a client who's going to have very loose speech, if you will, right? Loose association, I should say. The topic and the ideas, they do not follow each other, and then they're usually unrelated, jumping from one topic to another one. First one on the list we have is something that we call tangential speech. This is where they're going to change the topic from the original topic, the original question that you asked, and they never come back. They're going to change the story altogether. They're never going to answer your question. With circumstantial speech, yes, they're going to give you too much information, unnecessary detail, but eventually they will circle back and they'll answer the question that you just asked. So that's the difference. Of course, with derailment, they're going to change the topic altogether, and there's no connection. They're so unrelated. Clang association, clanging is just they're using some words that rhyme, and they are just, I don't know, random words, but random in a way that they're rhyming. For example, if you ask them, how are you doing today? And they'll say, well, I am great, plate, mate, gate. So, stuff like that, right? So it doesn't have any meaning, but there's a sound pattern, if you will, right? And then you have something that we call neologism, where neo means new. They're inventing new terms, if you will, language or words, I should say. And these are made up words that they're only meaningful to them. You have no clue what they're talking about. For example, they'll say, well, snow tie. I go, what's that? Well, you're talking through the walls, or split kippered. Well, what's that? Well, it's when you are living in California, and then maybe at the same time you're living in New York, or you're dead in New York, so different like terminology, made up words, and stuff like that. And then of course you have a word salad, and we all know what that is. These are like a jumble of unrelated words, right? Then we have echolalia. These are repeat words. It's whatever you ask them. For example, how are you doing today? And they'll say, how are you doing today? How are you doing today? And did you eat? Or did you eat? Did you eat? Did you eat? So usually whatever question you ask, they are going to repeat that. And sometimes not just with a client who's going through schizophrenia, or who has a schizophrenia, I should say, sometimes we see this pattern in autism spectrum disorder as well, right? Totally different type of concept, of course, but I just want to make that small connection here. So here you have an example of a disorganized speech. You can take a look at it. I don't have to read this. You can pause and read. And the second example is I try to read even a paragraph in a book, but it takes me ages because each bit I read starts me thinking in 10 different directions at once. Remember I mentioned earlier, you can only imagine when you have a client who's going through either auditory hallucinations or dealing with psychosis in general, where they're trying to focus but they just can't. So overall impact of that disease or disorder on this person is huge. All right, so we did A1, A2, and A3. Remember, those were the main ones in a way that a patient must have at least one of those, right? A1, A2, A3. Now A4 and A5, we'll do them real quick. A4 is when you have a client who's giving you a presentation of a grossly disorganized or catatonic behavior. This is when you all of a sudden you see agitation, you can't predict that all of a sudden, right? Difficulties with the goal directed behaviors, or you see catatonia, which is either motor immobility or excessive motor activity, right? Or abnormal posture and so forth. So that's your A4. All right, so the last one on the list is A5, negative symptoms. Well, before we talk about a negative symptom, I do want to introduce a concept of a positive symptom first. So what is a positive symptom? What's going on here? Well, let me give you an example, and then I'll make my point here. Examples we already covered. That was your A1, A2, A3, delusions, hallucination, your disorder thoughts, right? Now, why do we call them positive? What's going on? So let's pretend that this is a person, just basic, and I know I'm not an artist. I totally get that, okay? So do not judge me here. Okay, so this guy, okay, I wanted to make sure smiling, but okay, fine. Okay, if this is a baseline of a person, baseline, and all of a sudden now we notice either delusions or hallucinations and so forth, we can say that some of the traits got added to the baseline personality, let's say. And that's where the plus sign come from. And you're adding more, because baseline is your client does not hallucinate, right? That's a I hate to use this term, but normal, I should say maybe healthy individual does not hallucinate, right? So if you are hallucinating, then you added some more traits to your baseline personality, and we call that positive. All right, so that's where positive symptoms come from. Now, negative symptom would be the opposite. You actually take something away from the baseline personality, and we'll call them negative symptoms. What do you take away from somebody? Well, their mood, their expression. If you were able to smile and all of a sudden you can't show excitement or frustration, flat affect, right? That's negative symptom. Somebody removed that, took that away from you. Alogia, you speak very little or none sometimes, right? No motivation, that's another negative symptom. And anhedonia, at one point you were able to enjoy certain activities, however, you do not enjoy that activity anymore. You do not get a pleasure out of that activity, right? Remember, this is a part of the depression, right? One of the criteria. So you can say negative symptoms are pretty much like your depressive symptom, right? So positive symptoms, your auditory hallucinations, right? Your visual hallucinations. These are all positive symptoms. However, depression, flat affect, they're negative symptoms. So I hope it makes sense now. And they are a part of your diagnostic criteria. And that's why it tells you that number 4 or 5 cannot be one of the top 3. Remember I said at least one of them has to be either 1, 2, or 3, because if you just have negative symptoms, then that's a depression, that's not schizophrenia, right? All right, or if you have some psychosis with it, that will be major depression with the psychotic features. Now the third one on the list is, which is not a part of the diagnostic here that we are talking about, is, and very important in my opinion, is a neurocognitive impairment of these symptoms. What do I mean by that? Well, this talks about the overall effect or impact of this disease, and it may be independent of what type or what degree of positive or negative symptoms do you have. It's overall, how do you live in a society? Are you able to um, go to work? Can you get up at 4 a.m. and set your alarm and then go to bed early, drive, take a shower, go through the interview process or fill out the application? Most of them can't. At least in my patient population, they cannot. I'm not saying most of them as a general population. There are many individuals with high functioning, as I mentioned before, right? But at least the patient population that we serve, they are not able to go through interview process and so forth. So there's a huge neurocognitive impairment. Remember earlier I mentioned, every time you have a new episode, think of having a stroke, if you will, right? That's an analogy that I gave. So there's a brain damage. Sometimes it's irreversible. And on top of that, by the way, the medications that we are giving, they're also causing some deficit in cognition, if you will, unfortunately. So these are heavy duty drugs. We'll talk more about drugs in part 2, by the way. So take a look at these symptoms, but A5 is actually negative symptom. That is the main criteria here. As I mentioned, overall loss of function. They cannot maintain social norms, may dress very sloppy to bizarre or not appropriate. If it's 110-degree outside and they have sweater or jacket and so forth, so it doesn't match. Remember, that's a part of our mental status exam anyways, right? We talked about that, wearing scarves and so forth on a hot day. Or they may display inappropriate behavior, maybe sexual inappropriate behavior and so forth. All right, well, let's see if you are paying attention or not. So I have a quick question for you. Difficulty remembering what to buy and which aisle to find the groceries in, and being unable to select options quickly enough on a self-checkout at a grocery store suggest impairments in what cognitive domains? And see if you can answer that. And I'll give you a few seconds if you can pause. And now I'm going to give you options and see if you can find the option that you had in your mind. Was it a positive domain, or a positive symptom, negative, or is it neurocognitive, all of the above, or none of the above? Again, take a few seconds and see if you can answer. And of course, the right answer is neurocognitive. Remember, cognitive impairment in visual memory and processing speed, remembering which groceries are needed and which aisle to find them. It indicates deficit in visual memory, right? And also learning memory. Now, difficulty in reading and responding to visual prompts on a checkout screen, that also indicates impairment in processing speed. So they all fall under neurocognitive disorder, which most of my clients struggle, at least the one that I treat inpatient. Remember, so at that time, most of them do struggle. So you see the overall impact. It's not just getting rid of hallucination or getting rid of negative symptoms. Negative symptoms, by the way, are very difficult to treat. I always see this as like an onion, if you will, right? These are layers. So you, when you have a client, I think it's worth having a discussion real quick. When you have a client with multiple symptoms, the first one that we treat is your positive symptoms, and we'll talk more about that in treatment plan management lecture. Start with the treating, auditory hallucinations or visual and so forth, and then once the patient is stable enough, then the patient will tell you that, hey, I don't enjoy things. I remember one time my patient told me, how come I don't laugh the way you laugh? How come I don't enjoy my life? It seems like I'm not having fun, and that really breaks my heart. So I sat down with him and I said, well, you don't remember the day when you first got here, and the fact that you're having a conversation about your mood, that tells me that you're doing much better. I'm glad we're having conversation. So let's have so we talked about this concept that what the positive symptoms were, and then they are improved. Now I'm working on the negative symptoms, right? So very, very complex, case, of course. All right, okay. So, all right, it's time to play a game again, right? Truth or lie. So let's see if number one is a true statement or not. Schizophrenia means split or dual personality. What do you think? I'll give you again a few seconds to pause. And the answer is it is a myth. It's a false statement. Now, even though the term itself it does mean that it's split or dual personality. However, that is not the case though. We know now very well that this has to do with the thought and language and not personality. So it's actually a misnomer. So it is a false statement. All right, schizophrenia is rare. What do you think? Well, that's not true either. The lifetime prevalence of schizophrenia is about 1% worldwide, so it's not rare. It's pretty common, right? The problem is there's a stigma attached to it, and remember there are many either cultures or countries where most people do not get the part of that data either, right? So that we do have a problem with that. Clients with schizophrenia are prone to violence. What do you think? Again, I'll let you pause, and the answer is false. It's a lie. Now, you may have a client, who has schizophrenia, and they do commit crimes, and some are very dangerous. I see that, but the majority of these individuals are not violent. Although these patients are rarely dangerous to others, they do carry a risk of suicide that is very high. And according to one study, it's as high as like a 10% or so. So it's worth emphasizing here that a client who has schizophrenia, they carry a very high suicide risk, possibly the highest of any psychiatric diagnosis. So there is a dangerous component to self, but not a necessary violent to others though. So please keep that in mind. Next is schizophrenia is caused by family dysfunction. What do you think? Well, again, that's a false statement. Now, psychological factors may influence the way individuals or families cope with schizophrenia, right? But families do not cause schizophrenia or any mental illness for that matter any more than they may cause a cancer or high blood pressure, and stuff like that. So I get it. There's a family like a history, and that's important, genetics, but we cannot say that family dysfunction causes that, right? While the biological factors leading to schizophrenia is clearly a disease of the brain and not a primary psychological disorder. So please understand that part. All right. Schizophrenia is present in every culture, religion, race, gender, and socioeconomic. That is a true statement. I don't think one religion or one culture can claim that if you worship this way or my way, and then you will not get this disease or any disease for that matter. So I respect all culture and all religion, of course, but we do not have any data where we can say that there's a discrimination here, right? The disease starts around adolescent age. That is a true statement. We know that. All right, let's see. So that this is a true statement, right? These are true statements. Okay, all right. Next is we don't know the real cause. That is also a true statement. There are many theories, and increased level of dopamine is a big one, but again, we don't know the exact cause. There's no cure. That is also a true statement. We have a lot of medications to manage their symptoms, but we do not have any cure for it. Okay, this is the last one. Is very interesting. To date, no cases of schizophrenia have been documented in individuals with congenital cortical blindness. In other words, people who were born blind. Do we have any a documented case of schizophrenia. So what do you think? I'm going to let you pause and answer this question. And the answer is, this is a true statement. So research suggests that congenital blindness may prompt the brain perhaps to recognize and strengthen non-visual like a cognitive symptom, for example, like auditory processing. Remember, we talked about that, auditory and visual and all that, and maybe that function protect these individuals. In other words, we really don't have, at least I'm not aware of anybody who was born with congenital blindness and has a diagnosis of schizophrenia. If you came across one, please let me know. All right, I think that's all I have. And I know it was a long lecture. I do apologize for that, but make sure you take a break now and come back and watch the second part, where we will go over the dopamine pathway and the treatment plan, most importantly, psychotropic medications and their side effects and so forth. Okay. All right. Thank you so much. Let me know if you need anything. Bye-bye.